Right, good morning everyone. My name's Naseer Ahmad. I'm a vascular surgeon from Manchester. And today I'm going to be talking about what we're doing in Manchester, and particularly about the MARS project, which is the Manchester Amputation Reduction Strategy. And it's a sort of a whole systems analysis, and hopefully we'll sort of get some lessons about what good can potentially look like. As a bit of background, this is where I work. I work at the Manchester University Foundation Trust. It's a huge organisation. It's got well over 1,000 beds. It's got a turnover of £1.6 billion. There's over 20,000 people working there, £1 billion in pay and 600 million in non-pay costs. It's just humongous. A bit about me. I come from a public health background. So before I did medicine, I worked in public health, and my big interest is health inequalities. And for my doctorate, I looked at health inequalities of amputations. So I looked at 100,000 amputations across England and described, probably for the first time, inequalities in different areas. I've got a big interest in non-medical professionals taking on a lot of medical jobs. This makes a lot of people really nervous, right? I've supported district nurses, podiatrists, and tissue viability through their independent prescribing, and I'm a big supporter of doing a lot of the jobs that vascular surgeons traditionally do. Like Leanne, I work on the National Wound Care Strategy. Leanne's the leader, and I have to sort of bow towards her, because try arguing with Leanne, it's just don't do it. I also work with Health Education England, looking at the lower limb capabilities framework as well, and I also work with a parliamentary group looking at lower limb ulcers and amputations. As a day-to-day, this is all a preamble to what I do, by the way. I'll get down to the main presentation in just a few minutes. My day-to-day job, as a vascular surgeon, I do the full gamut of vascular operations. So I mean, this week alone I've done 2 aneurysms. We had a rupture just a couple of nights ago. But I specialise in the lower limb, and I do what we call sort of pedal bypasses. This is where, I don't think the pointer doesn't quite get to it. So I do pedal bypasses onto the foot vessel itself, onto either the dorsalis pedis or the posterior tibial or the plantar arteries. These vessels are about a millimetre in diameter, and I sew onto those, and we've managed to reduce the amputation rate by 23%. 23% over 3 years. It's not just me that does this. There's a whole team of us. I work really closely with our podiatrists, with our specialist nurses, with the dietitians, and there's a whole team of us that do all this. And as I say, we've reduced amputation by 23% in 3 years. That's compared to a national reduction of 18% over 10 years. And we've only done this by all working together. So we've done quite a lot of good work. So back to what I'm talking about. So MARS is, as I say, it's a Manchester Amputation Reduction Strategy. And what we want to do is reduce the number of amputations across Greater Manchester. And the way we want to do that is to improve the care for all ulcers and standardise the way that ulcers are cared for. And by removing that inequality, you can make things a lot better. But we want to do more than that. We want to incorporate social care, NIT, and various other clinical pathways that are going on at the moment. We've been given some money to do a business case for change and do a deep dive service review, and that's what I'm going to be talking about today. MARS is one solution to 5 problems with 8 proof of concept projects to highlight what the solution is. And the first thing you have to understand is you've got to understand the pyramid of disease. Right at the top, you've got people who end up with an amputation, but there's a whole group of people underneath. And a solution to reduce amputations has to affect all these people. So you've got to have people stopping getting ulcers in the first place. You've got to have a solution for people who have ulcers but aren't getting healed. And then finally, those to get to the hospital itself. And what do you do about those people? As I said, there's huge inequalities in amputations. The amputation rate is 30% higher in the north of England compared with the south, 3 times higher in men compared with women, 69% higher in the black population compared to the white population, but 40% lower in the South Asian population. Yes. And ulcers is a huge problem. Just for Greater Manchester alone, we spend about £200 million a year on ulcer care. And that's predicted to rise to over 350 million within 5 years. Nationally, it's about 5 billion, going up to about 8 billion within those same 5 years. And the national inequalities we have in amputations are also within Greater Manchester as well. So if you can address those inequalities within Greater Manchester, you've got a blueprint for a national solution as well. So the first problem we're trying to fix is this. Everybody knows about diabetic ulcers. Everybody gets it. There's a national strategy for it, and everybody understands that a diabetic foot ulcer leads to an amputation. Everybody gets it, and for good reason too, right? 10% of the population aged 50 and over has diabetes. 10% of the diabetic population has a foot ulcer, and the risk of amputation and the prevalence is at least 10 times higher. And we know diabetic foot clinics reduce amputations. We know all this. And that's why there is a national program for this. What people forget is that the opposite is also true. 90% of the population does not have diabetes, and 1% have a foot ulcer. And if you multiply that out simply, 10% of 10% is one person, and 1% of 90% is one person. So we have the same number of people with foot ulcers who are diabetic and not diabetic. But if you're diabetic, you get access to all the services that you need for that foot ulcer. But if you're not diabetic, you don't get access to those services. So you've got this perverse scenario where you have podiatrists and nurses, wishing diabetes on their patient who has a foot ulcer so they can get access to those services. And that is an inequality which we need to address. Okay. I'm going to say something controversial now. So not only do we have diabetic foot ulcers and non-diabetic, we've got other campaigns as well which are doing phenomenal work. Okay, so you've got the leg ulcer campaign, Stand Up for Feet, and you've got Stop the Pressure as well. And they're raising the awareness of these ulcers. But they're also embedding one of the problems that we have, which is this idea of a silo mentality. An ulcer is an ulcer. A pressure ulcer, a foot ulcer, a leg ulcer is essentially the same thing. And the treatment for them is essentially the same. Get the pressure off, keep it clean, get the edema out, make sure it's got a good blood supply. It's the same for all of these. But what you have is foot ulcers being done just by podiatrists, leg ulcers being done by tissue viability. Who does a pressure ulcer? Maybe a bit of both. What happens when it's on the heel? Well, it's not quite me, it's not quite. All that's got to stop. You need lower limb wound care specialists who know it all. So, the first problem, you have diabetic foot ulcers, you have non-diabetic foot ulcers, you've got leg ulcers, which is a much bigger problem, and everybody forgets about lymphedema. It's a huge problem which is just not being met. And the four main conditions, as we know, diabetes, venous insufficiency, venous disease, peripheral arteries, and lymphedema. And the link is high-risk population get an ulcer who end up with an amputation. And in Greater Manchester, we have about a million people aged 50 and over. About 300,000 have these chronic diseases, 4,500 people with ulcers, and about 1,000 amputations. And this is the population in Greater Manchester. 4,500 people with 7,000 wounds being seen on average twice a week for 30 minutes at a time. There's a huge variation in that range, and some people are seen 30 times a week, some of these people. But the issue is much bigger than ulcers, right? Half of all wound care is delivered in the patient's home. These are the patients who are have dementia, socially isolated, and they're frail. How do we get social care to these people? So we want to address that problem as well. Third problem is doing nothing is not an option. The first line is the do nothing scenario. It goes up and up. The yellow line is if you can simply reduce the prevalence by 3% a year for 5 years, so 15% reduction over 5 years, you will offset a lot of that rise. That's all you got to do, 3% a year. The fourth problem is vascular reconfiguration. Many of you may be aware of this. So in Greater Manchester, we have 3 vascular centres, and the vast majority of vascular work is lower limb. And now the whole population of Greater Manchester, which is 2.8 million people, they go to 3 vascular centres. That's going to come down to 1 vascular centre over the next couple of years, which means all those population, I know Dad's army, right? So they're all going to come to that 1 arterial centre, which is where I work. And that means that it's all going to come to a halt. You're not going to get 3 times the number of resources, you're not going to have 3 times the number of beds, 3 number of ITU, so everything grinds to a halt. So there's a problem with vascular reconfiguration. Because vascular surgery is basically 4 operations, right? That's all we do. We do carotids, we do aneurysms, we do lower limb bypasses, we do amputations. That's all we do. Reconfiguration reduces inequity, right, which is true. So all the evidence says if you have your aneurysm done in a major centre, your outcomes are better. If you have a bypass done in a major centre, your outcomes are better. If you have it's all correct. The problem is, what if you can't get into the centre? Which means that everybody's still stuck on the outside. So you're aiming to reduce an inequity, but you're actually generating an inequality because people can't get in and out. So you've got to address patient flow. Okay. The 5th problem, the final problem we want to fix, is the idea of the inequality in service provision in the community. If you have foot ulcers, you generally go down the left-hand side, leg ulcers down the right-hand side, and who you see and where you go depends upon where you are. We have 10 CCGs, 10 different ways of doing things. Some places are really good, other places need to be a bit better, right? So there's 10 different ways of doing it. We need to try and standardize all that. Vascular surgeons love this diagram. Do you know why we love it? Yeah, because we're in the middle. And we love being in the middle. We're surrounded by all this work. Okay. So these are just the problems we're trying to fix, right? So all ulcers, we want to have a shift towards prevention and healing faster, coordinating care and incorporating social care. So what are the principles upon which we are basing the solution? Number 1 is, there's no money out there. And there's no people out there. We know the whole problem about bursaries and nurses not coming through. You're not going to get any nurses or any money anytime soon. We're just going to have to make do with what we have for the moment. We already know how to treat ulcers. It's not hard. There's no magic dressing. There's no magic wire, no magic stent. Drug companies don't like it when I say that, right? It's simply doing the basic stuff really, really well. And it's the aggregation of marginal gains. Do all those small things, they'll all add up together to a big thing. And finally, if it was easy, it would have been done. There's nothing easy anymore. An asylum mentality. Everybody talks about this. I don't know what the answer is to it, but tell you what the answer is not. The answer is not increase the size of your silo. You've just got to think differently. So there's about 50 of us working on Mars in different ways. And so we've got a steering group, we've got 2 operational groups in Manchester and Salford. And we're doing a service review of these 2 areas, looking at guidelines and putting together key performance indicators, putting together what the IT should look like as well. And we want to work across schools, social care, as well as public health. And we're working with the Director of Public Health's office and the schools and schools body as well, and the council as well. We've got to do an economic analysis, and we've got a research and publish group as well. Because we've got about 6 organisations, we need to have a whole media strategy to coordinate message. It looks really quite complex, right? But if you take a step back and look at it, it's really quite simple. Right? It's really easy. So what's the solution? The first thing is we're quite lucky in Manchester, all right? We've got control of our own health budget, and they're really encouraging novel and innovative ways of working. And there's something different about the people of Manchester as well. So what is life like on Mars? What could it potentially look like? Okay, so this is what we want to try and develop. So we want to bring together a wound care team in the community, so bring together district nurses, podiatrists, tissue viability into one wound care team managed by a non-medical consultant. And that team is integrated with the hospital team. We have a single point of entry into that community team, and that community then has access to all these services out there. So one referral point, and that's linked with podiatry, tissue viability, with burns, with dermatology, as well as the health and social care team. District nurses are absolutely crucial to all of this, and we're really engaging with them to make sure that happens. There needs to be proper coordinated protocols across all these, and everybody needs to speak with the same language to each other. And then we're going to have tier 1, tier 2 and 3 care, but tier 1 is district nurses, tier 2 is specialty clinics, and tier 3 is the MD team. And what we want to do is ensure that the diabetic foot clinics see non-diabetics, the leg ulcer clinic sees lymphedema as well, and to ensure that we have MDT clinics for leg ulcers as well, where we have leg ulcers, plus you also have a medic there, a microbiologist, and all the other specialities that traditionally foot ulcer people have. We're also working across schools as well with a Healthy Schools project to make sure that often if you can't get to patients, you can get to their kids, and the kids can kind of affect their parents. So and we're also working with the Skills for Life team to encourage kids to have more confidence within themselves as well. So there's a whole project going along those lines as well. I'll skip through all that. So basically, Mars in a nutshell is creating these individual wound care teams